As stated, I'd like to state the following again. I've just started the recording of the open meeting in compliance with CMS. For the record, prior to doing so, I announced that Palmetto GBA would make an audio recording of the open meeting and consented on behalf of Palmetto GBA. With that being said, let's go ahead and start with our first presenter. Dr. Grand, I think you're up. Should we go on to the next presenter maybe and then go back?
We can if they're on.
I believe the next presenter is Dr. Cockrell. Is he available? Then I guess the next presenter would be Dr. Brent Moody. Dr. Moody, are you available?
So I'm Dr. Brent Moody. I'm representing the American College of Mohs Surgery. We support this LCD as written. We find it to be reasonable safeguards for patients. And the LCD is very similar to the current LCDs that surround Mohs micrographic surgery, which we also support. And skin cancer is so prevalent that these LCDs are necessary to safeguard the integrity of the program and to protect beneficiaries from unproven and medically unnecessary services and protect the agency from abusive billing. Next slide, please. So I'll just call this to your attention. It was published in the Journal of the American Academy of Dermatology in 2024, and it really gives a snapshot of where SRT and particularly IG-SRT have headed in the recent past. Next slide. And it really revolves around several services, the first being the radiation therapy service, CPT 77401, which is the actual delivery of the energy to the tumor. And it also focuses on ancillary services, notably simulation services that are listed below, and image guidance, which is, of course, part of this LCD. The simulation codes are part of the concurrent coding and billing guidance. Next slide, please. And you can see what we've observed is tremendous growth in all of these services, average annual growth rates of 30, 94, 90, 230%. The ultrasound guidance has gone from less than 5,000 in 2016 to 133,000 in 2021. Those numbers continue to grow. Next slide, please. So we believe that this proposed LCD is based on a comprehensive literature review, which demonstrates that SRT is not first-line therapy. Also, it demonstrates that IG-SRT, image-guided SRT, is no better than standard SRT. It simply requires documentation as to why SRT is being utilized. It does not restrict SRT in any clinically significant way when it is clinically indicated. So we do not believe this LCD will prevent any suitable patient from receiving SRT. The tumors highlighted in red are all ones that are approved by this LCD, and that is the vast majority of skin cancers. So despite this being a very modest LCD, there has been a lot of orchestrated activity by physicians and corporate interests who profit from this procedure. The vested interests really want to preserve the status quo. Next slide, please. So I liked to frame my thinking and ACMS's thinking about this is let's forget about those interests and let's root this in science. So the National Comprehensive Cancer Network is a neutral arbiter. They don't answer to corporate interests. They don't answer to specialty societies. They don't answer to physician financial interests. They don't answer to elected officials. They only answer to data. And if you look at the most recent guidelines for basal cell carcinoma, it's very clear. Radiation therapy is for non-surgical candidates. There are other easier, cheaper, and more effective ways to treat low-risk skin cancers. Next slide, please. And for high-risk skin cancers, again, they recommend Mohs surgery or this thing they call PDEMA, which is another way to say Mohs, or standard excision, or for non-surgical candidates, consider discussion of definitive RT. I could do this for squamous cell in situ, but they all say the same thing. So next slide, please. This is really the heart of the matter. as I see it. So the LCD states that the use of high-resolution ultrasound to guide SRT delivery and to assess lesion reduction during the superficial radiation treatment protocol is not considered reasonable and necessary and not supported by the literature. We agree with that provision. And I think this really cuts to where a lot of the concern is from the corporate interests in this procedure. Basically, adding ultrasound guidance to superficial radiation therapy generates an additional $3,000 to $4,000 of revenue for the practice for each cancer treated. Now, if the evidence showed that it was better than standard SRT, that would be perfectly justifiable. But there is no evidence to support IG-SRT is better than SRT. Next slide, please. So the so-called evidence, proponents cite several articles to make claims such that IG-SRT is superior to SRT. They claim IG-SRT is superior to surgery and that it should be first-line therapy. Well, if you just take a critical appraisal of the published literature, you'll see that none of these claims are supported. And those who wrote the LCD came to this conclusion. Next slide, please. So what is the evidence? What's the reality? Not what we hear from corporate interest. There are no direct head-to-head trials comparing IG-SRT to SRT. So there's no way to make a definitive claim that IG-SRT is superior to SRT. Zero head-to-head trials. The publications that are frequently touted have industry-conflicted authors and are funded by industry. There is no prospective randomized controlled blinded trials comparing IG-SRT with standard SRT or surgery. These are published in low quality, low impact factor, pay-to-publish journals. There's no publications in support of IG-SRT in flagship journals. They're poorly or non-matched or non-existent comparator cohorts to try to make these claims. There's no blinded central review of efficacy, which is a hallmark of every skin cancer trial in which I've been an investigator. It's a blinded central review of efficacy. There's little reporting of adverse events, tremendous loss to follow-up. Two of the papers that they tout the most have 85% of tumors lost to follow-up. Another one they frequently cite, 98.6% of tumors were lost to follow-up at 5 years. 5 years follow-up is standard for an oncology trial. So the authors of all these papers assumed everyone lost to follow-up did not have a recurrence. So again, these studies are not prospective, not randomized, not controlled, and not blinded. So it's really, I think the obvious conclusion is why these were published in such low quality pay-to-publish journals, because they're weak papers. I review for the Journal of the American Academy of Dermatology. In the last 3 years, I've reviewed 47 papers, and I wouldn't accept any of these. Next slide. Of the 12 that they cite the most, again, 0 are randomized, 0 prospective, 0 have a control group, 0 have a blinded central review. 10 of the 12 have industry conflicted authors or funding. Most of the journals have very low impact factor or no impact factor whatsoever. They're in pay-to-publish journals. And 2 of them aren't even remotely related to oncology or dermatology. So again, this is just very low quality literature. Next slide, please. This is one they'll frequently cite. Again, it's in a pay-to-publish journal, low impact factor, no comparison. Their primary assertion is speculation and conjecture. It's not randomized, not controlled, prospective, no adverse event reporting. The only inclusion criteria was completion of 20 fractions. So if a patient had adverse events or had disease progression while undergoing treatments, they were excluded from the trial data. And nearly half the patients had less than 12 months follow-up. Next slide. Another one that's frequently touted in the journal Geriatrics, which is not an oncology journal. Very similar, not randomized, not prospective, no control group, 100% retrospective, no adverse event reporting. They tout large numbers in this trial. They say that 20,000 patients, but large numbers don't correct for flawed methodology. It only amplifies the flaws. And look at this dropout. By 2 years, 60% were lost to follow-up. By 4 years, 85%. by 6 years, 98%. How can they make any claims about efficacy with that degree of loss to follow-up? I've done clinical trials. If I had this many patients lost to follow-up, the central trial monitor would be in my site wanting to know what was going on. And yet this got published in a so-called peer-reviewed journal. This is scientific malpractice. Next slide, please. Same thing. They claim that doing daily ultrasound is important and that daily measurements result in more efficacy and less toxicity than standard SRT. Again, no control group of patients who receive standard SRT. How can they say that IG-SRT and doing these measurements is better than not doing them without a control group? Again, non-randomized, non-blinded. Same applies to toxicity. These claims are simply not supported. Toxicity data was only available for 18.8% of patients. Again, very poor trial methodology. It wasn't even a trial. It was just retrospective review. This should not have ever been published. Next slide. So the other thing that's really fascinating to me is there's no evidence that these daily alterations in the ultrasound images actually reflect tumor changes. They don't consider alternate explanations. We know that ultraviolet energy, X-ray energy, superficial radiation therapy, it's on the electromagnetic spectrum right next to ultraviolet injury. When you injure the skin with anything on the electromagnetic spectrum, one of the consequences is dermal edema. It's why you get edema after a sunburn. So they have invalidated that what they're seeing on ultrasound actually represents a histologic alteration in the tumor. Next slide, please. So some of these final considerations, there are no high quality studies comparing SRT versus IG-SRT, which is why we as the Mohs College, we support SRT in appropriate patients. The radiation field can be set by examination. Skin cancers that are amenable to SRT are superficial without extensive dermal involvement. These small measurements make no difference. Skin cancer doesn't grow day to day. There's no reason to increase the field. Alternatively, there's no data that say you can decrease the field. No validated protocol for assessing what you're seeing on ultrasound corresponding with a clinically meaningful endpoint. And the literature is very vague on what is adaptive therapy. They say we adapt the therapy during treatment. Well, I don't see that. Next slide, please. So at best, I think it can be considered experimental. Now, I personally think it's very cool. I mean, this is cool. I love technology. By our rare nature dermatologists, we love lasers. We love all kinds of cool technology. And this is cool. And patients like it, but that doesn't make it medically necessary. My stage 3 and 4 melanoma patients would love to have a PET scan every day to see how they're doing. But we don't do it because it's not medically necessary. Next slide, please. So despite this lack of evidence, there has been tremendous growth of ultrasound guidance. It has just exploded, as you can see here. And this trend continues. Annual growth rate of over 200%. Next slide, please. Well, why are they doing this at all? If you look at IGRT, image-guided radiotherapy, from Astro, they say it's where external landmarks are not reliable. Well, you're looking at the skin. This is for morbidly obese patients or patients factor with a decreased reproducibility of the treatment position. It's on the skin. You can look at it. It's not going to move. This isn't like prostate cancer where the position of the bladder can affect things. So it's just not medically necessary. Next slide. And this was never meant for the way it's being used. If you look at the practice expenses in this code, this was meant for people being subject to probes. That's why glutaraldehyde is in there, to clean a scope. So dermatologists code prolifically with this, but I don't think it was ever appropriate. So I think elimination of coverage of ultrasound guidance will eliminate this incorrect coding. There are a small subset of dermatologists, as elucidated in that JAD paper, that are billing this with every fraction. I found one dermatologist in Texas in 2023 collected $1.2 million of ultrasound guidance for skin cancers. Next slide, please. Provider qualifications, this just says you need to know what you're doing. There are provider qualifications in the Mohs LCD, which we support. So I don't think it's unreasonable for people billing for these services to be able to demonstrate they're qualified to do so. Next slide, please. Electronic brachytherapy, we also support this part of the LCD. Next slide, please. So our personal view is this will help the conscientious provider. You know, physicians who are providing medically necessary services should welcome this LCD to get rid of some of the bad actors who are abusing it, who are abusing this technology. My other question is, if this is so amazing, you know, why is it not in better journals? So I think honest players should really embrace this. You know, they'll get paid for the work they're doing while reducing inappropriate actions. Do I have additional time, or am I out?
You can go a couple more minutes.
So I think this might be my last slide. I don't know, is this my last slide? Okay, so, you know, again, this is for appropriate tumors. It eliminates medically unnecessary and scientifically unsupported image guidance. Again, I think this should be accepted. And if new data emerges, high quality data, we can revisit that in the future. We also support the coding advice that's part of this, particularly limiting the use of the simulation codes. We think that's another area of abuse, that dermatologists are billing simulations with every fraction of radiation treatment, and that makes no sense whatsoever. Radiation oncologists on average use 1 to 2 simulations per cancer. Dermatologists are using 10 to 20. So we support the coding documentation as well. And with that, I will end my comments. Thank you.
Thank you, Dr. Moody. If we can go back maybe to the first presenter, if they're here. Dr. Grand, you can go ahead if you're here.
Hey there, I'm Dr. Kimberly Grande. I'm a board certified dermatologist who's been practicing dermatology for about 25 years. I did internal medicine prior to dermatology and trained at Baylor in Houston, right next to the MD Anderson Cancer Center. And we had a very heavy cutaneous malignancy background in my residency training, and I've carried that on practicing in suburban Knoxville, Tennessee, where we have a lot of underserved areas from southern Kentucky, northern Georgia, and western North Carolina that we serve as a hub for cutaneous malignancy. I am not Mohs trained, and through my training, it was very evident to my partner and I, Dr. Meredith Overholt, who've been practicing together since that time. She too is from Baylor, that if you're not Mohs trained, you don't do Mohs. But unfortunately, in my area, we have very few Mohs trained, Mohs micrographic surgeons, and we do have several other physicians who practice Mohs without that fellowship, and that she and I are curious about how that actually happens or what they feel their qualifications are to do that. But because this is an underserved area, people do go to them to get their skin cancer treated. The people that we do refer to for Mohs, since it's not done at our center, oftentimes have a 3 to 4 month wait before they can get seen for their skin cancer. Oftentimes, unfortunately, because the lesion is rapidly progressive, they have to go to University of Tennessee, Knoxville, in my town, to the the Surgical Oncology Center, or to ENTs to be seen, which of course is seeming to be out of the specialty of dermatology. But you got to do what you got to do when you have a person that can't get into somebody for Mohs micrographic surgery. We have been doing image-guided superficial radiation almost out of means of necessity in our practice since April of 2019. We have together seen over 1,200 patients that we've practiced image-guided superficial radiation therapy. And I just caught the end of Dr. Moody's presentation. I believe that's who was before me, and felt a little bit taken aback by some of the things or accusations that people that do image-guided superficial radiation are trying to get away with. We're not trying to get away with anything, but we're really trying to use within the means of our practice and our expertise, a way that we can use a technology that started in the hands of the dermatologists in the 1940s, of course, fell out of favor when Mohs micrographic surgery came on the scene. We're not Mohs surgeons, and that I wasn't adequately trained in image-guided superficial radiation therapy, but with the partnership of radiation oncology, we've been able to understand how to best apply the science and the technology to our patients to get them started and get them finished with their treatment of their skin cancers before they'd even get a chance to get into the door, the Mohs micrographic surgeon, or for another surgeon to work on their skin cancers. My partner and I do cutaneous surgery, but there are certain areas and certain skin cancers that are not amenable without the guidance of sections of frozen sections to make it legitimately a Mohs surgery. So we are really working in our backwoods area, if I can say it that way, to take care of our patients in the best way possible. And that there are patients that travel greater than 120 miles round trip in order to come 3 times a week to our center for a 15-minute appointment, and that they're very happy to do so because they don't have to go have Mohs surgery or wait until they can finally get in or travel a very long distance in order to get there. I find that the image guidance in superficial radiation therapy is incredibly helpful for me as I look at the patient and treat the patient over the period of time, which is usually 20 or 21 treatments. Most importantly, in the simulation that we only do once prior to making our plan for superficial radiation therapy, really does tell me a lot about that skin cancer, and that the high resolution ultrasound really does tell me about the depth. And with superficial biopsies, there are several times that you have a squamous cell carcinoma in situ that might be diagnosed on pathology, but when you look at the high-res ultrasound, you can see that it's much deeper than the superficial biopsy would be, and that these biopsies are also done in outlying centers, and that the patients, because they are looking for an alternative and tired of waiting for their next Mohs appointment, have sought us out as a referral center, that they do come from us, from other dermatologists or other providers after a skin cancer has been diagnosed. So it helps us make a real-time decision during, first of all, it helps us make sure that this patient is an appropriate IGSRT candidate, because if it's too deep of a lesion, greater than 6 millimeters, sometimes even greater than 5 millimeters, and let's clarify what's superficial. There are superficial skin cancers which are confined to the epidermis, and there are skin cancers, several of them that do go metastatic or down to subcutaneous fat. So when you discuss superficial, sometimes that gets confusing in the way in which physicians talk about that. If it is in situ lesion, or if it truly is just in the skin, which by an oncologic surgeon standard would be considered superficial in comparison to a systemic like abdominal cancer. But when we do the image guidance, that really does tell us where it is and where it isn't. And if you can maybe recall, or if you know anything about how this goes, we don't actually have an opportunity to put the little tattoos on the skin in order to make sure that our cone or our customized metal shield is placed to the exact millimeter of what our treatment field has been planned from the first simulation. So it gives us real-time decision making on making sure that we are at the exact lesion, because it does shrink over time. And then also I will say that there are lesions that grow over time. Many of the squamous cell carcinomas that show up in my office, the patient has a history of it only being there for 3 or 4 weeks, and you can imagine that those cells are still there, still rapidly reproducing. And so it can do quite a big change from the time of which it was biopsied until the time that Mohs surgery or image-guided superficial radiation therapy is actually initiated. It has a really great cure rate. So I've seen these patients since April of 2019 in follow-up. And to my knowledge, I cannot think of one that I've seen recur. And this is in contrast to those patients that have had Mohs surgery, which are not always 100% cures. There are certainly those that have recurrence on them. It's a non-invasive therapy. I've also seen patients come after Mohs surgery on eyelids that were sent to the oculoplastics, and their eyelid was sewed shut for 6 weeks while it was healing. You can only imagine the morbidity associated with having your eyelid sewed shut and patched for 6 weeks. We do image-guided superficial radiation on eyelids with metal shields. We also do it in the external auditory canal of the ear, also on the helix of the ear. This is so important because the vital structures in front of the ears and including the facial nerve are in there. So you want to make sure that you are adequately treating the tumor as time goes on with each radiation fraction. So the real-time image guided helps us make sure that we're not getting a too aggressive tumor in the time it takes to treat. We have made decisions based upon that to debulk tumors or to say that the IG-SRT is not the appropriate treatment, and from there have to refer them out to the appropriate surgeon to be treated. If we didn't have the image guided technology through the high-res ultrasound, I don't think I would be able to be as precise as I am in treatment, and it really is beneficial in decision-making and taking care of the patient. I find that the patients also find that interesting because it's right there on the screen when they're sitting in the chair, that they have this sense of reassurance that their skin cancer is melting before their eyes with each additional treatment, which I think is always a nice thing for the patient to be kind of involved in their care along the way, or understanding that if it's time to switch modalities, change your treatment protocol, why that is being done. I think in contrast to sending them to a big radiation mega center, they feel that they're more at home in a small center where their skin cancer was diagnosed, and they feel like that we know at the Skin Wellness Center, we know cutaneous malignancies, as opposed to we've had people go to the big radiation centers and actually being sent back to us because the radiation oncologist cannot identify where the skin cancer was, and they need us to actually put our mark on the skin and then send them back to their center on the same day so that they can identify where the lesion is, which makes me think that those type of scenarios are prone to failure about treating wrong site areas. In conclusion, I find it interesting that the Palmetto audited our IG-SRT services recently, and in 2024, the appeals for per treatment image guidance came back as 100% favorable. Let me say that again, 100% favorable. That per fraction IG-SRT has met the standard of medical necessity and was considered reasonable for payment. And I'm not sure why a new technology that provides over 99% cure rate with low morbidity, and I follow these patients long term. It's not that it just it's not a 6-month cure rate, that they are incredibly happy, and that in my underserved area where there are not very many Mohs micrographic surgeons, that this is a way that I can provide state-of-the-art care for my patients when the older modality of Mohs micrographic surgery may be inappropriate for that patient. And if I were asked to do superficial radiation therapy without image guidance, for me, it feels like I'd be the Mohs surgeon who was being asked to do Mohs without frozen sections. It's shooting in the dark. So the image-guided technology for me is very helpful in making sure that I provide the best and most up-to-date cancer treatment that I'm allowed to with my training.
Thank you, Dr. Grande. If we can go ahead and go to the next presenter, please.
Yeah, my name is Clay Cockrell. I'm a dermatopathologist and dermatologist in Dallas, Texas. I also am the chair of a residency program, DFW Lake Granbury Dermatology Residency. We have image-guided SRT in our training program, and use it in one of our clinics here. So basically, just as a bit of history, I was trained at New York University Medical Center back in the 1980s. We actually were trained in SRT. During that time, we used the classic Siemens universal device. And we were all trained at putting in lead shielding and all the various kind of typical radiation treatment. There was basically, there weren't too many centers that were teaching radiation therapy at the time, but I was actually trained in it. And my father and grandfather were both dermatologists, and they used radiation therapy for the vast majority of their skin cancers for many, many years. And I sort of had I've been in practice since 1986. And so I've watched the advent of Mohs surgery go from not even being basically invented, if you will, and watching it be attacked very much like Dr. Moody attacks this technology. It was originally attacked by pathology, who said that Mohs surgeons weren't qualified to look at slides. It was also attacked by the plastic surgeons, who said that dermatologists shouldn't be doing surgery and doing flaps and everything else. So it's kind of ironic that they actually eventually were successful at getting their technique recognized in medicine, but now they're sort of doing the same thing to radiation therapy that was done to them years ago. So I've sort of seen this turf battle go on for many years. I've been an advocate of Mohs for many, many years as well. When it first came out, I said, this makes all the sense in the world. You're histologically guaranteeing that a cancer is removed, which is better than doing blind surgery. We look at pathology specimens from plastic surgeons and general surgeons. Their margins are far greater positive than Mohs surgeons. And this is analogous to Mohs surgery in many ways. We know what the cure rate is for routine SRT, which is about 97, 98%. This technology improves that to over 99%. And again, I'm not here to talk about the necessity of doing daily or routine imaging at each stage, but I think doing the mapping the tumor at the beginning and certainly mapping it at the end and maybe monitoring to the middle to make sure that it's responding to therapy makes all the sense in the world. And just because it hasn't been written up and studied and published in large major journals, that doesn't mean that it doesn't work. And when Mohs was first coming out, they weren't published in the New England Journal of Medicine either. So this is a technology that makes perfectly good sense. It's reasonable. It increases the cure rate from, and here's some examples of how this works in vivo. You can see the tumor going away during the treatment and seeing it at the end when there's nothing left there. And so basically, to me, this is something that is a reasonable technology. It improves what we already know is a very good technology, makes it more, you can actually follow it and demonstrate that it's getting better with a device, as opposed to having to do, say, a post-operative biopsy or something along those lines. One other thing I'll speak to as a dermatopathologist, we get superficial shave biopsies most of the time with our cancers. And a lot of times when we see these excised by routine excision or by Mohs surgery, we see that there's a more aggressive area to the cancer that wasn't detected upon the biopsy. So if you're going to treat someone with SRT, you can document that even though it looks like it might be a nodular basal cell, there might be a sclerosing basal cell element near another area. You can document that it's responding to the therapy by using the image guidance during the treatment. So it makes sense to do it. These show some of the long-term cure rates with this. And so I think as time goes on, the 6-year study, the technology has only been around for about 5 or 6 years. So we don't have long-term data on it because it hasn't been around that long. But there eventually will be long-term data that proves that this improves the efficacy and the cure rate of just routine SRT, which we know for many years what that cure rate is. So it just basically makes reasonable sense to do this. There are always going to be providers that can game the system. We talked about one provider that got $1 million worth of revenue by doing image guidance. Well, the average Mohs surgeon makes anywhere from $1.5 to $3 million on average just from Mohs surgery alone. So I don't think we should be talking about monetary things here. I think we should be talking about whether this makes sense, if it's scientifically valid. And I think we are going to get more and more studies that come out and show that it is something that's reasonable. We teach it in our program to our residents, and we're going to continue to do that. I think that providers, when they graduate from their residency program, a lot of new technologies come out. They have to go to postgraduate residence training. So just because somebody didn't get this in their training doesn't mean they can't learn it and apply it and do it like Dr. Grande does it in her practice. So Personally, I think this is something that should be approved. It shouldn't be restricted and shouldn't be disallowed to have dermatologists have this as an opportunity to use it for their patients. I don't think most people do this as a primary form of treatment, but patients that have had many Mohs surgeries don't want to get additional Mohs surgeries. A lot of patients are not good surgical candidates. So it's something we need to maintain and have in our therapeutic armamentarium. And this is something that improves SRT as opposed to just SRT alone, since it's got the image guidance component to it. That concludes my comments, and thank you for listening to me this afternoon.
Thank you, Dr. Cockrell. If we have the next presenter.
My name is Robert Burnside. I am an employee of Electa Company. I am speaking and giving information on behalf of clinicians who cannot join due to technical difficulties with the presentation. I want to start by commenting that the clinicians that I'm speaking for have no comment or information to add about the high resolution ultrasound IGSRT portion of this LCD, but they do want me to indicate what's at stake in the LCD as it is currently written. If the current proposed LCD policy is adopted and coverage is eliminated for electronic brachytherapy, which is abbreviated as EBT, thousands of skin cancer patients, and the majority are Medicare beneficiaries, would be denied coverage of high dose rate electronic brachytherapy, a viable, safe, and highly effective non-surgical treatment option to cure their skin cancers. This slide shows one of the three main technologies that's used to deliver this technique, which is a variation of superficial radiation therapy, but with the significant difference of a individual dose of more than 400 centigrade per treatment to the cancer lesion. So this is a hypofractionated treatment that is done over 8 to 10 treatments rather than the 20 or so treatments that are typically given for SRT. So this is a very big difference in the protocol and also in the resources, equipment, supplies, and time it takes to safely deliver the hyperfractionated treatment. So what is the concern with the draft LCD? In particular, there was one guideline that was, I hadn't advanced yet, but that's okay, that was cited in the LCD called the Consensus Guidelines for Radiation Therapy for Skin Cancer, which was published in February 2019. That guideline, which was cited, did not include any long-term clinical data that exists for electronic brachytherapy. No electronic brachytherapy physician users were included in the formation of those consensus guidelines. The authors of that guideline were conflicted as they were members of the medical advisory board of a competitive therapy manufacturer, and they did not include the electronic brachytherapy clinical data that was available at that time. As it turns out, more than 10 years of safe clinical use of electronic brachytherapy supported by extensive peer-reviewed clinical literature was not considered in that 2019 clinical guidelines, which include 14 published papers to date. Advanced slide, please. NCCN, AAD, and ASTRO societies all endorse surface radiation therapy, SRT, as a definitive option in non-surgical candidates due to these cosmetic, functional, and patient preference concerns. Next slide. Electronic brachytherapy, which is a high dose rate variation of surface radiation therapy, is entirely aligned with this principle. And because of the intense dose treatment and the shortened hyperfractionated course of treatment requires a collaboration that is key to the successful delivery of this modality. It is proven as an effective, well-tolerated modality for these appropriately selected patients with low and certain high-risk non-melanoma skin cancers, particularly those who are non-surgical candidates. These studies are hyperfractionated studies. They're more modern, they're more standardized than the SRT publications, And many of the SRT studies that were cited in the LCD used older regimen and lack uniform dosimetry. There are no randomized controlled trials that compare electronic brachytherapy versus SRT. None of them prove superiority of one of these modalities over the other. The high dose rate electronic brachytherapy recurrence rates, cosmetic outcomes, and long-term tolerability compare favorably with SRT and even with surgery in certain select cases. Next slide, please. This is a modality that is being used for thousands of patients per year. And again, as I had stated at the beginning, these are patients that would be denied coverage of a viable, safe, and highly effective treatment option. This is because the current code, which is 0394T, is going away at the end of 2025. Astra revised CPT codes to include or put high dose rate electronic brachytherapy under SRT. In September 2024, at the CPT editorial panel meeting, Astra created new CPT codes, which will be effective January 2026, which bundle high dose rate electronic brachytherapy into the code for SRT, currently called 77X07, and deleting 0394T, which was previously used for electronic brachytherapy. At the May 2025 AMA CPT editorial panel meeting, Astra opposed creating new separate CPT codes for high dose rate electronic brachytherapy, advocating for reporting both high dose rate electronic brachytherapy and SRT under code 77X07, stating that all services reporting using this code are reasonable and necessary. This alignment acknowledges that both high dose rate electronic brachytherapy and SRT utilize similar photon energies and treat the same anatomic conditions. Next slide, please. So these are the three different machines that can treat this hyperfractionated protocol. It is typically only 8 to 10 treatments. They are operating at an energy of 50 to 70 kV in order to allow this hyperfractionation of greater than 400 centigrade, and the treatment depth is significantly different because of the need to deliver in such a hyperfractionated regime. As was stated earlier, this type of treatment requires a collaborative approach. A AART certified radiation therapist is always involved, remains in the room during high dose rate electronic brachytherapy treatments due to less radiation scatter, assuring that quality care delivery. They are always supported by a board certified radiation oncologist and a medical physicist. These assure the highest quality of care delivery due to the ultra high daily fractionation. State regulations require a radiation oncologist to be involved with this type of treatment for electronic brachytherapy of skin, and this is because of the high daily dose given. Next slide. Again, showing that the type of isotope brachytherapy that the hypofractionated regime originally came from, and these are delivered with this type of applicator, 8 to 10 treatments, just like electronic brachytherapy. Next slide. Again, showing the difference in the distance between the source and the tissue between electronic brachytherapy, shown above, less than 6 centimeter, and SRT, shown below, 15 centimeter. This difference in distance between the source electronic X-ray tube and the skin allow the hyperfractionation and the delivery of the entire course of treatment at 8 to 10 delivery sessions. Next slide. Again, just showing that those distances are different. Next slide. Again, showing some of the literature that was omitted from the LCD. Next slide. And some of the studies in detail. Next slide. Advance. Okay, so again, our ask at this point, we respectfully request that the section describing the elimination of coverage for electronic brachytherapy be deleted from the draft LCD policy, because Ionizing radiation, as produced by high-dose rate electronic brachytherapy, is proven to cure skin cancer. High-dose rate electronic brachytherapy is proven safe and effective with minimal side effects and excellent cosmesis. Certain cancer patients can benefit from a viable non-surgical treatment option with high-dose rate electronic brachytherapy. Thanks for your attention.
Thank you. Melissa, do we have any other presenters?
We do. We're going to have two presenters from the schedule for the JM open meeting this morning who are going to present now. So we have Dr. Farberg first, and then we're going to have Dr. Scott around 2:15.
All right. Go ahead, Dr. Farberg.
Hello, and thank you for the opportunity to speak here before the board. I really do appreciate the MAC's continued effort simply to try and get this right, as you guys always have. I'm Dr. Aaron Farberg, a double board certified physician in both dermatology and micrographic dermatologic surgery, Mohs surgery. I have no conflicts to report nor perceived conflict like many may have, as I do not make my primary income through providing SRT, IG SRT, nor performing entirely Mohs surgery, which we can all see as a conflict. Now, I have reached out to several of the radiation companies for more information, and I've also recently published a few articles on the topic of IG-SRT. And I'm also made aware of, the goings-on as a member of the Durham CAC and previous deputy chair, and I'm also on the board for the American Academy of Dermatology's Clinical Guidelines Committee. So, why my interest? Well, one of my research fellows had studied and published IG-SRT. So, like any good physician, I was cautious and perhaps even skeptical of the treatment. So I chose to review some of the evidence and most importantly, gain clinical experience. My interest in such treatments actually started during my medical training, which was, many years at the University of Michigan for medical school and plastic and reconstructive surgery residency, where I spent almost 7 years as a lead in the craniofacial research laboratory, which is a combined collaborative lab with the renowned radiation oncology laboratory under Ted Lawrence, who's a past ASTRO president, ASCO board member, better known as the founding father for radiation therapy for the treatment of head and neck cancers, another topic that I've studied and published on during my time there. You fast forward now, and I now have several of my own medical dermatology private practices, but I'm most proud that we are directly affiliated with the dermatology residency program, where we train 3 residents a year, total of 9 residents in our program. And I can assure you that our dermatology residents all receive education and clinical experience with image-guided SRT in the clinics. Now, I believe others will or have already, with Dr. Cockrell speaking to, the training point, as well as the position from the American Academy of Dermatology, but, simply the idea that SRT should be utilized only by radiation oncologists or require some, government mandated specialized training when we dermatologists have been safely and effectively treating hundreds of thousands of patients for decades is simply preposterous. Furthermore, given the large private equity-backed radiation oncology roll-up down the street from me, which apparently performs the same IG-SRT with even more visits at 26, according to my patient who had it done, I have doubts that costs will be conserved by one specialty over another. Anyways, I feel like I have to explain why I'm speaking the way I am. In somewhat of an unclear manner. And you see, I've had a surgery for my jaw in the past few months, and it was a functional issue. And so, after trying several other interventions over my lifetime, I needed to proceed with surgery to fix my breathing and my bite occlusion, which brings me to a very important point. Anyone who's paid attention in medical school, particularly the surgery clerkships, they understand that surgery should be a last intervention, not a first line. Now, I wish I hadn't had my surgery, but, Of course, this doesn't include, by the way, trauma, surgical emergencies, functional necessities like mine, and of course, certain elective procedures. But, even the good surgeons know to call other doctors or use other therapies first sometimes. Surgeons are performing less and less in favor of their own medical management of disease, or by calling other colleagues such as interventional radiology to place a drain, interventional cardiology to fix a valve, or even med-onc to utilize immunotherapy. All of this instead of surgery. So I, for one, I really hope that we've progressed from Mohs surgeons performing 20 plus Mohs surgeries every single day as the only skin cancer treatment option by the time I'm 65 and a Medicare beneficiary and need a skin cancer removed from my nose. And by the way, yeah, I'm working on that, not just here with IGSRT, but yeah, I'm a PI for a study for intralesional immunotherapy for skin cancer, which may be even more impactful. And by the way, may cost even more than Mohs or IGSRT. So you see, the other fields are being allowed to advance, but this LCD is restricting specifically to Medicare beneficiaries seeking dermatologic care. As with IGSRT, we dermatologists can utilize that therapy to help our patients. So, now with the brief time I got, I'll go through the slides here, but, my goal is to make the points that I've made. And of course, I wanted to include all the references so that, you medical directors can review the data yourselves and, perhaps some of these citations that were missed. This, you already know what IGSRT is. Next slide. Here, you've read all the benefits of IGSRT. This is what my patients get to enjoy. And again, if it was you on the other side, sitting in the patient chair, you'd want this option too. And it should be discussed as opposed, to a patient being forced into Mohs as the only option because of the doctor's conflict of interest. Next slide. Here's what an ultrasound does in case you missed it. It was, the primary imaging method that we used at the University of Michigan, and we have several on every floor of the hospital because we all know how to use them. Somebody compared it to, doing a PET scan for every melanoma. Again, I don't see how you can make that comparison of a PET scan versus a, safe ultrasound, but that's their choice. So, visualization here allows for monitoring the lesion and thus adoptive therapy, just like my wife had done every time she went into her obstetrician during our pregnancies. She received an ultrasound at every visit, including the weekly ones, which we had for our high-risk twins. Every week, an ultrasound, billed and paid for. I'll note, I never found any published evidence or necessity for it, but rather common medical sense prevailed, and it was paid for. Next slide. So here's kind of the goal to set the stage for, what we see clinically, and that there is data and several published articles that were not cited in the LCD. IGSRT, the 99% cure rate, it's in the published literature that we see clinically, as you've been told before. Next slide. Again, it doesn't matter what type of non-melanoma skin cancer it is, squamous cell or basal cell, and the treatment cure is durable for 2, 4, and 6 years. Next slide. So here is the published or a published study that illustrates an issue that previous SRT studies not utilizing ultrasound, revealing that SRT is inferior to image-guided SRT. And this makes sense. Previously SRT was performed in a variety of ways with a variety of devices. Similarly, Mohs can be quite operator dependent, which explains perhaps why the study on the right showed IGSRT is superior to Mohs. Is that true always? Maybe, maybe not. But it means that they're at least equivocal in efficacy. And we all can't go to see the world's best Mohs surgeon. A previous speaker talked about access. And we know that there is a skin cancer treatment access problem And the Mohs College, in limiting the training of these surgeons, has unfortunately, made this problem worse. We've gone backwards in what the goal, I think, was, which is access. Next slide. Here we have a retrospective cohort study looking at many non-melanoma skin cancer lesions treated with IGSRT. It showed the high cure rates that we see clinically. Yes, it's retrospective, and follow-ups are not what we could see in a large prospective study, but it's important data to see and review. It tells us that when you utilize imaging prior to modified radiation delivery, we may expect a 99% cure rate. Importantly, it also shows that other factors such as tumor location, patient gender had no impact on these outcomes. And yes, I'm also a reviewer for top, journals. And although that, there have been comments criticizing the journal titles, I'll also highlight that there are obvious politics involved here. So let's not overlook that. Next slide. So how often can one expect to see changes, with the image guidance of IGSRT? Fairly often, about maybe 40% of the time. So now a skeptic can continue to argue if the changes are big or small, can they make a difference? And well, the published data on this IGSRT says it does, and that the efficacy and safety, well, it's got to come from somewhere. Is imaging needed at every visit? Well, these IGSRT studies had imaging at every visit. So the answer is yes, until perhaps, any of those critics or the NIH or MAC or somebody wants to fund a study to evaluate exactly that, and they can do fluctuations. Maybe we only need the first 10. Maybe we only need one. Again, this study, this is how it was proposed, this is how it's been evaluated, and this is the result we get. So we have to stick with the data that we get. Until then, we have to utilize really the data we have. But again, I hope somebody does these studies in the future. Also of note, because there's been discussion on appropriateness of IGSRT based on tumor risk, and the NCCN was brought up. Many of and also said that they're unbiased, which is an interesting comment. But many of these lesions were deemed high risk according to NCCN guidelines, by the way. Now, next slide. Another missed article that I believe Dr. Cockrell covered for the LCD. Does the type of non-melanoma skin cancer matter, basal cell versus squamous cell? The answer is nope. You can do the next slide. And the next slide, you've seen some of these cases already. Next slide. So perfect. Here's the overall summary. I know we are talking about Medicare beneficiaries, so this isn't Burger King, and thus patients can't always, quote, have it your way. But if you are going to undergo SRT, then, the burger should be safe, it should be accessible, and at least cooked properly, which means image guidance is part of the superficial radiation therapy. Next slide. And here's all the references, to please consider and include for the medical directors. Thank you again for your time. And I do appreciate the MAC's, and all the medical directors' effort to simply try and get this right. Thank you again for your time and attention.
Thank you. If we can have our next slide and presenter. All right, Dr. Scott, you may proceed.
And thanks all for being flexible. I realize this morning's meeting time didn't work out, and I'm glad I was able to move my clinic around a little bit to be here. All right.
We appreciate your flexibility.